Assalamu alaikum. The long clinical consultation day. First scenario, Julia Smith, 30 years old lady, came with presented with loose stool. Please take history, examine the patient, address her concerns. So Muhammad ready?
Yes, Dr.
Yes.
Hello, I am Dr. Muhammad. I am one of the doctors here today. I need to confirm Mr. Julia Smith, 30-year-old, with me.
Yes, I'm the same. Yeah.
Okay, we are here today to discuss some health issue for you. I will take some history and examine you. Sometime I'll write notes. All my talk will be confidential if you don't mind. It's okay for you?
Yeah, that's fine.
Can you tell me, in your word, what brought you today to the clinic to can help you?
Yeah. So basically, I have been getting these loose stools for the last 2, 3 months, and they are not getting better. So I discussed with my doctor, and he referred it to you.
Sorry, what's happened to you, Ms. Julia? I need to know more about this lose emotions. It's first time to happen to you.
Yes, it is actually the first time. Yeah.
Okay. How it's started gradually or suddenly and increasing or decreasing?
I mean, I feel that it has been gradually getting worse.
Okay. You noticed this happened after specific meals or anything happened before this?
Not really. I do feel that it is more or less happen anytime.
Okay. How many times per day this happening?
I mean, you can say around 4, 5 times.
Okay. Uh, does it awake you from night?
Yes, it actually does couple of times. Yeah.
Okay. Uh, can you describe it as for me? It is watery or semi-formed or
I mean, it's more kind of a watery.
okay. You notice anything changing the color, any slim or any bloody or any dark color?
I have not noticed any blood in that. What else?
Any difficult to flush? You are feeling comfortable after going to the bathroom?
I mean, at time, yes, it could be. I mean, but generally it's okay. It's mainly loose.
Any greasy or oily?
No, I haven't noticed that.
Any specific smell there?
No smell.
Okay. Uh, anything increased? You notice increased during stress, during anything?
No,
You tried any medication or going to GP giving anything for you relieve it?
I have tried some anti-diarrheal. My GP, I think that he gave me some loperamide, but
Hmm.
I think that I'm not comfortable continuing with that. It does help at time, but obviously the moment I stop taking it, the problem again come back.
Sorry for that. Did you notice any abdominal, any tummy pain with it?
Yes, I have some tummy pain as well. Yeah.
Can you tell me where is the site of the pain or general all over the tummy?
Yeah, it's mainly in my upper tummy.
Upper tummy.
Yeah.
Sharp or dull pain? Can you describe it?
Well, I mean, it is something kind of a burning pain, which at time can get very severe.
Okay. Does it? Can you score it from 1 to 10? How much it is severe?
I mean, it's variable, but at time it could be around 6, 7. So,
Sorry for
yeah.
that. I can offer for you any suitable painkiller until we finish our. Okay.
Sorry?
I can offer you some suitable painkiller until we finish our examination. Okay.
Yes, I think that that would be appropriate if you can give me something.
Okay. Thank you. Welcome. Can you tell me, please? It is referred going to any way around the abdomen or the back. This pain.
No, it doesn't radiate anywhere.
Okay. Did you feel any swelling at the same site or anywhere in the tummy?
No,
Okay. Any feeling sickness or throwing up?
Occasionally, but not regularly.
Okay. Any units, any sore in the mouth?
No,
Difficult swallow?
no swallowing difficulty.
Okay. Any feeling you are telling me there is heartburn. This is started since when?
Again, last 2, 3 months.
Okay. Is increasing also by the time?
Sorry,
Increasing by time?
the pain.
Yes, the burning pain. You are telling burning pain. There is.
Yeah, I mean, obviously the symptom at the moment this seems to be progressively getting more worse.
Okay. So wake you from night feeling something acid in your mouth?
I do at time wake up at night due to the pain.
Okay, sorry for that. Any change for your weight?
I have not checked, but I feel that I might have lost a little bit, but I'm not sure how much.
You feel your clothes more loose?
Sorry?
You notice your clothes more loose?
No, not really. I mean, I haven't because I generally wear loose clothes, so I don't know that whether
Okay.
it
How much
has.
your weight? How much your weight average?
My actual weight was 60 kilos, but I haven't checked it again. But I can just feel that most likely I am shedding some weight, but I'm not sure how much.
Sorry for that. Any increase your blood temperature?
No,
Any lump or bump in your body anywhere?
no.
How you are compensating for this loose motion? You are taking more water intake?
Well, I do try, but then if I take more water and fluids, then I have to pee a lot. So I think that's why, and then I need to wake up again at night, and I have to go to the toilet to wee. So I think that's another problem.
Mm. Anyone notice you are more pale?
Not really.
Anyone notice your eyes more yellow?
No.
Okay. Before that,
I just
anyone?
I,
Yes,
sorry.
I'm hearing. Yes, I'm hearing you.
Yeah, yeah. Go ahead. I'm so there.
Okay. Any weather preferences,
No,
especially to the cold or the hot?
no, no,
Okay. Any past medical history of note I need to know, like diabetes, hypertension, anything of note?
no.
Any past medical family history of note, like giant gut tummy problem also like this?
I am adopted, doctor.
Okay, sorry for that. Any drug allergy, medication allergy?
No.
Any other medication you are taking apart from the loperamide or anything?
Yes,
Any
I'm just
antacid,
on some birth control.
birth control? Okay. Any travel history soon?
No.
Any taking any illicit drug? Sorry for this question. Regard to drug.
Sorry. No, no, no,
Any herbal medication using? Or,
no.
or any problem in your period? Julia? Hello?
Uh, yeah, yeah. I think that I feel that it is little bit irregular.
Okay. Any history of pregnancy?
I had couple of pregnancies. Yeah.
Last time when? Last child, how old is he?
It was 3 years ago.
Any miscarriage there? Any problem during any pregnancy?
No.
Any chance to be pregnancy? No?
Sorry.
Any chance to be pregnant?
No, I don't think so. As I said that my periods are a little bit irregular, but as I said that I'm on a pill, and I don't think that I'm pregnant.
Okay. The amount of it is okay, increasing or decreasing?
It's reducing. So my period, the bleeding, the blood in that, it has been reducing.
Okay,
I
مش
mean, my doctor told me that I might be anemic, and that could be, but I don't know exactly. So you are going to tell me about that.
Any joint pain?
No,
Any back pain?
not really. No.
Skin changes or
I
rashes?
no. I just wanted to tell you that one thing because I mean I had constipation for the last say year or so, and now recently I started having this abdominal pain and also having diarrhea. So my doctor told that it could potentially be something like a irritable bowel syndrome, but I don't know that obviously
Continues
because
not to keep that nebulizer.
You previous have hard stool, then started loose
yeah,
motion.
yeah. I mean, my bowels were absolutely fine a year ago, and then I started having hard stools, and that's something my doctor used to give me laxatives. And I had tummy pain as well at that time. It's a more kind of generalized pain. But now, and last 2, 3 months, it seemed that I started having uh, loose stools. So I don't know what's going on. My doctor think it might be IBS, but still, he want your opinion.
Mm. Any stresses in your life? Any mood problem? Anything in your what's your job?
Yes, I think that my mood generally is quite low.
Any stresses in your life? You can help.
Not really, but generally, I've noticed that my mood definitely has gone a little bit low. I feel more depressed as well. But there is nothing out of the ordinary in my life.
Okay. Any flushes? You feel flushes in your face?
Flushing?
Yes.
No,
Any feeling in rashes during exposure to sun?
no,
Any muscle pain during combing your hair? You feel any weakness?
no,
Any sore in your eye or
no,
vision problem?
no.
Any headache?
I do get headache, yeah.
You have headache?
Yes, I do get headache, yes.
Can you explain more about that?
I mean, it's a kind of a diffuse headache, and yeah, but more you can say in the top of my head and the front.
Coming especially at any time of the day, especially in the morning,
Yes, it can come anytime, but little bit more at time in the morning time, you can say.
feel increasing during coughing or sneezing.
Uh, a little bit, yeah.
Any vision problem?
I mean, I do feel that my nighttime vision is not very good.
You feel a change in your hand size or feet size, your ring.
Uh, you can say a little bit, yeah.
Any picture for the patient? Can I see?
Okay, I don't have any, but I have noticed that. I mean, my gloves, they are a
Ah,
little bit more tight to me.
okay. You feeling you are bumping to the side of the during driving or you are seeing the side of the way.
I think that that's happened once, so I'm not, I mean, very keen on driving at night now, but it has happened. So I nearly had an
Okay.
accident.
Okay. Can I examine you, please?
2 minutes left. I will add 2 minutes for the concern from now, Dr. Muhammad. Okay.
I can examine.
Yes?
Yes, I need to see, examine abdomen first. Any bump or any swelling there, hepatomegaly, splenomegaly,
Only diffuse tenderness, more marked in the upper abdomen.
in the upper abdomen. Okay, any masses there?
No,
Okay. How is the patient? Is cachectic or looks how is his weight? His weight?
seems fine.
Inside. Okay. Any sign of dehydration, skin trigger, or how is pulse and blood pressure?
No,
Blood pressure is okay.
blood pressure is 100/60.
Yes. Standing and lying.
Both the same, no postal drop.
Heart rate, how much?
But heart rate is around 80.
Any skin tanning or skin tightening? Any
No,
leukonychia? Anything in the hand?
no,
Any pallor? Jaundice?
Looks slightly paler, yeah.
Okay, I will open the mouse. Any sore there?
No.
Okay, I will check vision acuity and vision field.
Mm-hmm. What you want to check?
Acuity, right and left eye.
Uh-huh. Visual acuity seems okay, but there is
Field.
problem with the visual fields.
There is bitemporal myopia.
Yes, so temporal side there is problem. Yeah.
Okay, I will go to the any lump in front of her, the neck. I will examine. I give her some water. Any lump there, swelling,
No visible swelling,
any
swelling,
lymph node.
no lymph nodes.
Okay, I will ask her what is the concern.
Yeah, I just wanted to ask you that what exactly is going on.
Okay, Miss Julia. After taking history and examining you, we have a possibility of some growth in the some gland in your body, especially in the brain and some gland in your abdomen.
Mhm.
That's responsible about digestion uh, and in the brain, so causing some compression in your in some track on the vision. I'm advising you to stop driving now until we fix this problem, and we need to do some lab and urgent imaging to confirm our diagnosis.
Mm.
I'm gonna put
Doctor,
you in the
I'm
office and I
concerned.
can't reach finally. You know, we'll hook you up with Mr. Sammy. I promise. Yeah.
This condition called
I am getting paid for
multi-endocrine
little
neplasia.
stuff. Hey, just come over here real quick.
Sorry,
Would you mind and
Dr.
visit
Gautam, I
me?
think there's a lot of background noises. I don't know that.
Inside of one of my many living areas, as you can see, my base is
If
literally
you
full of
can
them.
mute the other people
You have three
for now.
guesses to guess which one I am inside. You have to just hit them, and if you don't guess it, you are.
Thank you. Yeah. So, doctor, I'm concerned because I had constipation, now I have diarrhea, and I have read on the internet that this could potentially be a sign of cancer. So, I'm very worried about that. Is that a possibility?
I appreciate your concern, Ms. Julia, and it is a possibility, and this is what we are feeling now. This is a type of a cancer, but we will start our management and will try to control it as early as possible.
Right. So, what you are going to do with me now?
We will admit you because there is some loss of too much fluid in your body, and start to giving some fluid your blood channels until become more good hydrated, and you become okay, and to start immediately to do some imaging to the brain and the abdomen to confirm our diagnosis, and we will share our gut doctor and brain doctor and start our management immediately.
So, I need to stay in the hospital.
Yes, we need to admit you today until if we finish our treatment and management to confirm our diagnosis.
All right. Okay.
Okay.
Any problem?
Examiner question.
All right. Okay. So, briefly present your case and give the differential diagnosis.
We have 30-year Julia adopted and presented with 3 months back of gradual onset progressive course of diarrhea with pain, especially in the upper abdomen, the gastric area.
Mhm.
On the examination, patient she has low blood pressure, some sign of dehydration. She's pallor, she's pale. There is bitemporal hemorrhagia on examination of the vision field. Some generalized abdominal tenderness, especially in the gastric area. Uh, uh, Taking all this together, my first possibility, men type 1. Uh, um, I ruled out any infectious causes. Fees also maybe drug induced by laxative she is taking, but
Sorry, drug induced due to what?
she's told in the history that she take too much laxative for the.
No, but at the moment she's not taking. She is only taking loperamide.
Okay, so this is a low possibility.
Mm-hmm. Anything else?
We have
So what is
pancreatitis also, chronic pancreatitis, but against that, no greedy or oily or stool.
Okay. And what is the cause of the abdominal pain and loose stool in this patient?
Pancreatic cancer are the part of min type 1.
Which pancreatic cancer?
Pancreatic
Adenoma, adenocarcinoma,
adenoma.
pancreatic adenoma. All right, okay. So this patient has some mood issues as well. What's the reason for that?
The mood issue because of hypercalcemia.
Mm-hmm.
Also history of constipation and this mood and this period disturbance. All this infiltration due to pituitary, due to parathyroid malignancy also.
Uh-huh. Right. So apart from pancreatic adenoma, anything else which could potentially explain the current symptoms she's having?
Spontaneous bacterial overgrowth maybe there also.
Spontaneous bacterial overgrowth. You mean
CBBO.
so small intestine bacterial overgrowth? That's what you are saying.
Yes.
Uh-huh. But has this patient given you any history of fat malabsorption?
Oh, this is a low possibility also.
Uh-huh. So any other possibility?
Gastric also gastritis or gastric masses.
Mm-hmm. Gastric masses, what do you mean by that?
Cancer, gastric cancers, stomach cancer.
Right. Okay. All right. So how are you going to investigate her?
Firstly, the patient is have symptomatic of volume loss. We will admit here and started IV hydration. Rule out any. I will send for VBG and chemistry and hemoglobin level to rule out any acute kidney injury and deal with it. Then I'll start to send for full pituitary to confirm the diagnosis, full pituitary hormone, and also pancreatic panel, amylase, lipase. I will send for calcium level, parathyroid hormone level, the imaging, MRI brain to rule out pituitary adenoma, and ultrasound abdomen, CT abdomen with contrast to confirm the to rule out also the pancreatic adenomas. Stool culture and analysis also.
Okay. So, what are the components of the MEN1 syndrome?
Pituitary, the acromegaly, and pancreatic gastric cancers like viboma and gastric and pancreatic, and parathyroid also, hypercalcemia.
Right. So, what type of pancreatic problem these patients can have?
Mentioned pancreatic adenoma.
Sorry? Pancreatic adenoma?
Adenoma. There is also with it. Also, the gastric lipoma and secretin hormone increasing. Really, I don't remember all the tumor.
All right. Okay. Right. All right. So,
Treatment.
yes, please go ahead.
Yes. Treatment, as we mentioned, as acute, we will manage as acute first to stabilize the patient, ABCD approach. Then, multidisciplinary team sharing the gastroenterology, neurologist, endocrinologist, education, counseling the patient, especially to stop driving until we finish this. If any alcohol, to advise to stop it. Also smoking, and the main treatment here, surgery, and for the acromegaly by surgery, transsphenoidal, sphenoidal, and the other one, and dopamine, octreotide, agonist, and also for the pancreatic surgery, and the medication, also the long-acting octreotide.
All right. Okay. Right. Any other? I mean, because this lady has two kids as well, so you want to advise further on that?
Yes. Sorry, I will refer her for counselor, because this autosomal dominant should be sent to the genetic counselor to and advise her for planned pregnancy next time to select the ova by the fertility and genetic counselor.
All right. Okay. I think that's
Yes,
it.
it's enough. 8 minutes now. Examination.
Yeah.
Let's add the comment, please.
All right. Okay. So, I mean, one question before I start. So, which component of the men one generally appear first?
I didn't confirm the patient about vision when she started really. I didn't confirm which one started first.
But my point is that that I mean, men one has three component: pituitary, pancreatic, and parathyroid. So, out of these three, which one generally appear first?
First, I think parathyroid first.
Yeah, so it's the parathyroid. I think that I mean, as we do, we just can go by skill. So let's go first to physical examination. Right. So I think that examination wise, you did cover most of the things, but you haven't seen things which could potentially be associated with acromegaly. I mean, you didn't ask and you didn't check for any signs of, you just asked about the pain and things like that. So I don't know whether it was pertinent to examine for any kind of a carpal tunnel in this patient, because if you have, so it is kind of an appropriate for someone who is having acromegaly. Apart from that, I think that you did most of the examination. All right. I think that there was no problem I feel that in terms of the examination, you did majority of the things which were required, obviously, because you need to do the targeted examination. So I think that was done properly. One thing you could have offered at the end, I mean, I don't know whether it was relevant, but could be considered, because acromegaly at time could be associated with colorectal cancer. So you can just, although patient does not have any history of any bleeding PR or anything, but still, I mean, you could have offered something like a digital rectal examination to look for any mass in that case. Finding wise, I think that you were able to pick up most of the findings. And as I said, that because you didn't examine, so you cannot comment upon the findings of the things like carpal tunnel and things like that. So this is something which, but otherwise, I think that you were able to pick up the findings which could potentially be there. Clinical communication, clinical communication, I think this was perhaps a little bit weak because you didn't ask a lot of things in the history. So I think that although you took around 12 and a half minutes for the history, but the reason is that I think that you make up your mind very late that this patient could have acromegaly or this patient could have a MAN1. So I think I understand that could be one of the reason, but history was quite patchy. You didn't ask about all the relevant symptoms of hypercalcemia. You didn't ask about uh, the patient actually gave you a clue as well that when you say that how you are compensating, and then she told you that if I drink more, then I have to pee a lot. So this means that the patient is not volume depleted, because if that person would have been volume depleted, so and if she is drinking, then obviously she should not pee more. So if she has been peeing more, so this means, and she said that this has been a problem. I already pee a lot, and then I have to take if I take more fluid. So this was a kind of a polyuria history, which could be due to hypercalcemia. So you didn't ask. I think I haven't seen you asking any urinary frequency and all these questions. I think that was one of the thing you missed. Uh, so I think so patient also mentioned about that mood changes, abdominal pain. So I think these are the things which go with the hypercalcemia. So you need to, and the patient told you that it started with a constipation. I had constipation for a year, and then now recently it seemed that I have been more kind of a loose stool and things. So it seemed that the things have shifted from one spectrum towards another. So normally, as I told you, hyperparathyroidism is the first component to appear in most of the patient, and then followed by pancreatic or pituitary component. So I think that's something which you'll need to see that what exactly is the sequence. But majority of the time, because hyperparathyroidism symptoms are at time so vague, kind like abdominal pain is so vague, mood changes are otherwise very common in a lot of other things. So that is why I mean it could have been missed for some time before being diagnosed. So this is the second thing. So that about the clinical communication. So clinical judgment, obviously, because this skill is linked with the clinical communication. So I think that's where you are also a little bit in a way lagging, because you are unable to find out that what exactly is going on till very end. Although you may reach the diagnosis, but you missed important links in between. So you didn't identify that this patient had a hyperparathyroidism on the history as well. So you didn't elaborate that. Differential diagnosis, men one was fine. Then I have read that you second differential you mentioned is pancreatic cancer, and you mentioned pancreatic adenoma. So generally people who have men one, so the reason for diarrhea could be multiple. So one of the reason, if you are talking in terms of the pancreatic issues, and so it could be gastrinoma, it could be glucagonoma, it could be VIPoma. So these all could lead to, and if you look into the history now, patient had a worsening abdominal pain and also having diarrhea. So either it was favoring towards a gastrinoma, or it was, and patient told you that symptoms have some kind of a diurnal variation as well. So it was going with kind of a gastrinoma, because there was no other symptom to suggest glucagonoma, like a rash, which is quite typical of a glucagonoma. So this was a case actually of men 1, but the components were which were present was primarily there was hyperparathyroidism along with gastrinoma, and then there is a element of pituitary adenoma with all these things. So this was the complete. So I think that differential wise, uh, you weren't able to mention the other things which could potentially be. Yes, you mentioned infection, which is definitely. So if you look into one by one, even I think that if you can just put in kind of a peptic ulcer, because the patient presentation is abdominal pain, so you can put it down as a differential diagnosis as well, because the patient have abdominal pain. And yeah, so that can also be one of the possibility. The other thing which could cause abdominal pain, chronic abdominal pain, uh, along with uh, along with diarrhea is something. I mean, if you have a chronic cholecystitis, but again, in that case, the diarrhea will be more having a fat malabsorption, so that will be more sticky. And so this is something. But again, I said that you need to put these two, three things in your differential. You mentioned one of the differential as gastric cancer. Uh, I mean, gastric cancer, I don't know that whether it will be a valid differential. I have no idea. You
I need to
mentioned
check
about.
gastrinoma, but come like this, Dr. Hisham. I
Yeah,
need to check
okay,
it
okay. Gastric, because you said gastric cancer, so that's why I was little bit surprised that
No,
gastric.
no, no. I wanted to tell gastrinoma, but all
Uh-huh,
cancer
okay,
pancreas.
that's yeah, yeah. All
If
right, then
Ebola came in my
yeah,
mind.
yeah. So yeah, yeah. So I think that's fine. But I thought that gastric cancer. Then you said about, I think one of the differential you mentioned pancreatic uh, adenoma, but I think that I don't know whether you document have written here that you mentioned maybe pancreatic cancer. I don't know that whether that's because the patient doesn't seem to have any risk factor like no history of alcohol, no history of recurrent pancreatitis, no. I mean, so that was also, I think, uh, I feel that was not a proper differential diagnosis. Apart from that, yes, you addressed the concerns very well. You didn't harm the patient welfare. So these things, I think they were done properly. Regarding management, I think you covered most of the things which were right. So genetic, I think that uh, genetic counseling was fine. And what else? I think that, yeah, you have asked about the headache. You have asked about the vision problem. You stop. Yeah, I think the other thing which you can put in the differentials uh, for this patient, obviously, although you didn't find any other thing to suggest, but I mean, considering that the patient have a pituitary adenoma, so sometime there could be thyroid abnormalities, which could, I mean, it could be a differential, but obviously because you don't have any other symptoms. So I think if we are just focusing on the abdominal pain and diarrhea, so we just need to, infection, as I said, is a very valid differential diagnosis, so you can give it like that. So yeah, I think that's from my side. But I think you did very well. But only thing I think that there was some issue with the time management because you will not be getting that much time in the exam. So you need to come up at least at 7 or 8 minutes to start examining the patient. And then if you find anything on the examination, then you can pick it up from there and ask question related to the finding which you have obviously not asked in the history, but when you have examined and you have picked up something, then you can ask in that the question about that. So I think yeah, but otherwise I think you did very well. The approach was fine. So overall, I think it was very good. Yeah, thank you.
Thank you,
Okay,
Dr.
thank you,
Hisham.
Dr. Hacham. You can post your scenario, Dr.
I will write it, Dr.
Delan, yes, for Dr. Hacham. I will start comment based on the skills because the exam is soon for both of you. Starting from the physical examination, yeah, I think some of the examination system are missed. So I agree to minus this as borderline. The second, identify the finding here also, since you catch some of the finding like by temporal hemanopia, by doing the fields, the abdominal examination you started with, the pallor, the hydration signs. I think also here you can also compare the hand size with your hands as well as the shoes or the feet size. So I could think you can get the satisfactory for the identify the finding. Clinical communication, I think you need to manage your time, Dr. Muhammad. You took long. However, there was some delay answers from Dr. Hacham. So I guess the exam, the surrogate will be faster. Anyway, if you have slower surrogate, I hope they will consider that. So raising the difficulty of the cases in our sessions as a training will give you the motivation to be more faster in the exam. If you miss the examination and the concern, believe me, you will be minus at least 8 marks. Okay, pure 8 mark, pure, without the clinical judgment. They can minus you in the clinical judgment. So the best way to avoid this, to train how to take the history quickly. And I believe you have still problem in the systemic review. What you miss in the system, and it didn't help you to catch the case, the urinary, as Dr. Hacham mentioned. You focus on the female history, but you didn't ask the urinary symptoms. That's why you missed the case. Please, whenever you start the package of history of the system review or systemic review, do it all. Don't be interrupted by any positive finding in between and focus on this and skip other system. You will miss a case. So finish the systemic review as a package. Then jump to the other, what you want to ask later on. The family, the travel, whatever. Okay. Then regarding the differential, yes, if you put the main one as a differential, then separate or isolated pancreatic cancer you can put as a differential. And you can put also another cancer in the colon, for example, you can put it. Yes, you can put this differential as either isolated or as a syndrome or as a combination. So you can gain the marks. However, in any diarrhea station or case, believe that you might have the irritable bowel syndrome, you might have the celiac, you might have the malabsorption. These are the most common. The analysis of your complaints from the start will guide you to the case. I think Dr. Muhammad was hesitant in the history or analysis of diarrhea here. I'm not sure if you ask about blood in stool, Dr. Muhammad. Is it flushing? I think you ask about flushing.
I think the complaint take much time from me because
Yeah,
it
yeah,
was
yeah.
I asked everything, blood difficult to flush away from to this
The relation to the food, yes, I remember that, yes.
any food related to food. First question, any relation to food from the beginning, yeah. But I miss really the urinary system. I should ask.
Yeah, not only the urinary, even feeling thirsty. Okay. This is regarding the differential. Dr. Hasham, I didn't say irritable bowel as a differential in this case. I'm talking about the possible differential in diarrhea in bases. You might have irritable as the commonest one. Okay, the celiac, malabsorption, these are the commonest. But in our scenario, difficult or it's different. You cannot say this is irritable bowel syndrome at all. Okay, because it's awake him from sleep. So whenever you have awakening patient from sleep, you can rule out initially the irritable bowel unless it's advanced stage. With the severe stress, sometimes it might awake the patient from sleep, but it's not usually happen. Okay, let's go to the next skill, which is the clinical judgment. Of course, if you couldn't catch the case, the whole discussion might be went to the wrong direction, and of course he can minus you because you didn't give him the case. So the management plan, some examiner either they will correct you and they will guide you to the questions regarding the case itself. Others they might go with you in the wrong way, and at the end they will minus you or give you unsatisfactory. So it depends on the examiner mood and your luck. So in this scenario, you can get borderline. So at least now 3 skills borderline. So you will have, if 2 examiner, you will have -6. Okay, if both examiner give you borderline, they will minus you 6 marks. Let's go to the last skills, 2 skills. Concern. Yes, it's if in the real time in the exam, you will meet the concern because you already passed the time of the case. You ask after 15. So the concern will be missed and the marks of concern will be missed. You can get 0 from the concern. The last one, the welfare. Yeah, you maintain the welfare during the discussion, so it's okay. And I don't think, but I saw some of the doctors, they have minus them in the welfare. So whenever the patient is saying or the patient hit his head or hit his feet to the bed or fall down, all the things they might minus you in the welfare. However, otherwise they are maintaining and giving you the marks of the welfare. So no one, usually all of the candidate can get full mark in the welfare. But be careful. Sometimes if you do a mistake with the patient during examination and the patient complain with any complaint, they might minus you. Let's go to your scenario, Dr. Ihtisham. 50 years old Miss Nadia complain of lethargy 6 months. Blood pressure is 110 over 60, heart rate 90, hemoglobin 7, MCV 110. Sit with her, take history, examine, and address the concerns. We will go back to the comments quickly. I think the one was active during the discussion, Dr. Aisha. Yeah, she started by pancreatic cancer itself can cause depression. Not only cancer or pancreatic cancer, not only pancreatic, every cancer can cause depression for the patient. Loss of appetite, loss of weight, so it can cause this. The lipoma, yes, one of the diarrhea cause and one of the differential. So you can say carcinoma, you can say lipoma, all of them neuroendocrine, all these are cancer you can put as a differential. But not, you can say it as a main one or as isolated one, particularly with diarrhea. Okay, but you have to put main one on the top of your differential. Yeah, I ask what else because I meant gastrinoma. By gastrinoma, mostly common with the main one. Patient pituitary panpituitarism, you mean? Pituitary, parathyroid, pancreatic, Dr. Aisha. This is for the main one, you mean, right?
Yes, sir. Yes, sir. I meant the men one has pit parapan. I mean, that's how I remember. It is pituitary, parathyroid, and pancreatic cancers. So that's how I remember.
Yeah, three
So it
P's.
was easy. Yeah, 3 P's. Yes.
Okay, what
So,
about men 2A and men 2B?
men two, you just forget the pituitary. There's no pituitary, so it's
Exactly.
parathyroid, pancreatic, and
What you can
thyroid.
replace?
The thyroid, medullary carcinoma of the thyroid, and then FEO. They both have FEO and thyroid cancer. And
So thyroid cancer, and you will remove two,
yeah, we'll
pituitary
remove
and
the
pancreas.
pancreas. Yes.
So
We'll
you
remove
will have parathyroid and you replace the pancreas and pituitary by
um,
fucosemide.
few. Yes, few. Yes.
Oh, this is 2B, 2A. What about 2B?
Angiolipomas for two Bs.
Okay, mucocutaneous, right?
Yeah.
Neuromas.
Yes. Yeah,
And
neuromas and same. FEO is there, and medullary carcinoma of the thyroid is there.
and one more. Very characteristic.
Marfans. Yeah.
Exactly, marfanoid.
Yeah. Marfan. Yeah, marfanoid.
You have to memorize all these components of all this differential like by heart. It's very common in the exam, either one or 2A or 2B. Okay.
Yes, sir.
Okay, thank you, Dr. Aisha. Let's go back to other comments. Yes, I corrected the hypocalcemia. It's not hypocalcemia. It was carpal tunnel.
Yeah. That's why I was when Dr. Hisham, Doctor, when he said that carpal tunnel, I was like, does he mean
No, he said
hypocalcemia?
carpal tunnel, not carbopedal.
Ah,
Yeah. I think
okay.
you hear it wrongly.
Yes. I heard it wrong. So I was like, carpopedal will be because of hypocalcemia, and that's how I was trying to correct it.
Yes, you're right.
Yeah. And
Okay. Yeah, what else you want to ask or you want to add?
I just want to say, sir, my exams is in February. So is it not any other way that I can participate, like presenting my case as well?
Yeah, sure. There is a possible way. Next week, hopefully, there will be some opportunity, so you can message me directly. I will arrange. Okay, I will arrange with you.
Thank you so much, sir.
Most
But I
welcome.
don't have a study partner. I mean, I see them always with the pairing, right?
Yeah, my session only like this online, and I will arrange another partner for you. Okay,
All right.
so yeah,
All
it
right.
will be like this.
All right. Thank you, sir.
Okay.
Thanks.
Thank you, Dr. Aishad. Hypercalcemia in man 1, hypocalcemia. No, it's no hypocalcemia at all. Both of them are hypercalcemia. Okay, we corrected that. I don't know why, Dr. Okay, there is this one corrected. The scenario, okay, Dr. Hisham, your scenario is in the chat box. Irritable bowel syndrome is not differential. Yes, I agree with that, but I'm saying you have to roll it out. By the way, I have short video about the differential of diarrhea. I will put it in the chat box so everyone can see it. It's very short. You can approach diarrhea with four questions. Every question will guide you to a type of diarrhea, and by this question, either to conclude or to rule out. I will share it while going the second discussion. Let's start, Dr. Hisham, if you're ready.
Yes, I just wanted to tell, I mean, obviously, this was in a way kind of a difficult case, but I think that Dr. Muhammad did very well because it covers a lot of system. Because if you only go into pituitary adenoma, so it can cause a lot of things. It could cause local effect. It could also cause, I mean, there could be secretory adenomas, and then you have to go and take all the scheme of thyroid, Cushing, and all these things, and then you need to look into the other components. So it was kind of a lengthy scenario, and I intentionally did it because I just wanted to practice it so that I do expect that
Yes.
in the exam. I think that
Yeah,
in the
yeah, yeah.
exam, most of the time they do give one component, and you
Mm.
can just quickly screen through that and you can tell. But I mean, it was just for the sake of
Absolutely
study and
right.
say yes. So I think that's why. So in the exam, I'm hopeful that it will not be like that. It will not be that. So most likely they will be just giving only one component and the differentials and all these things. But just for the sake of practice, so that even if we come across any difficult case, so you should be prepared. But I'm pretty hopeful that it will not come like this.
Yeah, yeah. I think the surrogates will guide you directly. They are helping uh, compared to the sessions. So don't worry about it, both of you. Be ready. You have to practice such scenarios as a complex of cases and the diagnosis, like men, like polyglandular. You have to do these. Diabetes, hypertension, the session we did a couple of days ago. So be ready to practice all such cases. They will not give you a clear, straightforward case. If it's there, be sure there is something hidden you have to discover.
Hmm.
Yes, you're right.
Yeah. All right. Okay.
Okay.
And thanks for Dr. Ihtisham, but one thing I need to comment, that's why I didn't go to the exam early, because I was lost really. I don't know يعني all my tracks يعني or approaches were going. Dr. Ihtisham is telling not too much, not too يعني about
Yes,
weight,
yes.
not too much headache I have. يعني if the surrogate there, yes, doctor, this you are right. This headache I have this since كذا. He will make me feel this is a very important يعني point that I catch it. That's why I
I,
was lost in
yeah.
between. I don't know يعني really it is only GI or يعني I came on my mind maybe some connective tissue, some surgery done, and after that there is complication because she is young, maybe bariatric, maybe like this. But at the end, the clue was in the systemic review. يعني the
Yeah.
point here is
Yes.
can
That's
really
why
systemic review. Mm.
I always focus in the systemic review. Believe me, you will catch something from systemic review.
You
It's
told a very important point, Dr. Basim, really, really, and تمام. Even you lost, يعني if you feel you are
exactly.
lost in the main complaint, يعني usually the main complaint he will give you
Yes.
one line to go with, and maybe at the same time he will misguide you, يعني maybe he tell you something
Mm.
waiting you to go to the social, to go to the systemic, to go to the constitutional, like this. So the very important point here, really, from this session, from this case, that once you feel nothing, all vague in the
Yeah.
moment.
Exactly.
So there is maybe
Exactly.
something there. I will,
Yeah.
يعني, the lesson here, go to the systemic fastly. Any
Yeah.
headache, any vision, any heart racing, anything. 1 minute, make a screen, or 2 minute, make a screen. He will
Mm.
give you clue. That's why really, really
Yes,
good.
I agree. I think that, I mean, yes, if you are stuck somewhere in the case, so I think that if you just focus on three things, you will definitely get a clue. One of them is a past history, past medical or past surgical, that will have some clue. There may be a hidden clue in the drug history, and the third clue will be in the family history, and the fourth one will be in the systemic review. So if you are stuck, I mean, definitely you will find something in these four components. And that's what happened here as well, that on systemic review. So sometime you might get clue. For example, if here, obviously the patient made it a little bit tricky to you by saying I'm adopted. So having someone said that I'm adopted,
Yes.
that should also, I mean, make you alert as well that okay, this means that there is a possibility, because
Yes.
that's what they do at time, that they tell the surrogate when they ask about family history, because then you will straight away go and you'll find okay, this is a problem in the family, and then they say okay, make it a little bit tough by saying that I'm adopted, so they will not be able to get the family history. But even if they say adopted, then you need to see that is it something potentially a familial problem or not.
Yes, this is another take-home message. In PACEs, usually, I am adopted doctor means something is there in the family. Either to be positive family, he will tell you, yes, I have my father has the same condition, so it's familiar. Or I am adopted, it's twisting answer, means that, yes, there is something running in family, but I want to hide this thing from you as a doctor. Okay, so be sure there is something, either yes or no. In the family history means there is a trick in the answer, either
Yeah.
positive or negative. So be sure there is something running in family, and he want either to distract or to help you. Okay.
Yeah. Yeah.
Yes. Okay.
Something also, Dr. Basim, lastly, sometime we are doing here, we are, as we mentioned, the surrogate, he will tell you or give you some alert that this is the history you mentioned. He will give you some alerts. Is very important. We are doing here sometime, and we feel that we are helping. You know, it is truly happening in the exam. Yani, if he feel that you are going the approach well and missed something, he may be alert you. He maybe give you some clue that yes, I have some medication. Take this is the paper of the medication list. Since I take this medication, happened with me. يعني sometime he will help you. He will give you some clue, but he should feel at least that you يعني catching the track. يعني you are on the track,
Yeah.
not way too much from the track. Once you are
Yeah.
like lost from him, he will came to you. He will not wait you to ask. He will came you to you by one clue. Only he will help you once. Then if you still lost, he will خلاص continue as you
Yeah, that's why, Dr. Muhammad, whenever you are lost, you don't know, you didn't catch, go through the systemic review. It will help you. Definitely, it will help you. Okay.
Yeah.
Yeah. Okay. Thank you. Let's start the second scenario. Dr. Hisham, ready?
Yeah. Yes, I'm ready.
Yes, here you go.
Hello, hi. My name is Dr. Khizar, and I'm one of the doctor here. May I confirm your name and age, please?
Yes, I am Miss Nadia, 50-year-old.
All right, Miss Nadia. So I'm here to discuss with you your health condition, and then after that, I will examine you. Is that okay?
Okay.
All right. I understand that you have been have feeling of lethargy for the last 6 months. Is that right?
Yes, doctor. Started with me since 6 months. I can't do my daily activity.
All right, I'll come back to that, but before going into further detail, may I know that have you got any other past medical history or any other surgical problem in the past?
Yes, doctor, I have diabetes since 15 years.
Right, right, okay. And is other than diabetes anything else?
No.
And have you been taking any medications?
Yes, I am on glycoside and metformin. Yes.
And you have diabetes for the last 15 years?
Yes.
All right, okay. All right. Uh, so if you can just explain a little bit more about your lethargy, that what exactly you have been feeling and what you mean by lethargy.
Yes, doctor, I feel my energy become more or less, and I usually having doing my work as an accountant and go very active and coming back to do my home for my family. Then nowadays, no, it's different. I feel not good.
Hmm. So you feel very exhausted.
Yes.
Hmm. And have you noticed any difficulty in breathing?
Especially when I am doing more effort, yes, I feel not my breathing not good.
Hmm. And after how much, I mean, exertion, you feel short of breath, like walking on a flat surface, or if you climb upstairs. So if you can just tell me that.
Yes. If I climb the stairs, if I going even walking fastly, I feel it is not my
And have you noticed any chest pain?
no. Only
All
my
right.
breathing.
Right. So do you have any loose stools?
Lose stool. Uh, Sometime I have it, but it is not bothering me too much really.
For how long?
Time it is not all the time with me.
All right. Okay. Have you wake up at night for these loose stools?
Be one time having with me, not all the time.
So just once at night. Okay. Have you noticed any blood in your stools or any black colored stools?
No,
Uh-huh. Any tummy pain?
to my pain, yes.
Where
Mild
exactly? Where
some full,
exactly is that?
some fullness after taking food only. Not pain as a pain. يعني.
Mm. So you feel fullness in your tummy after taking meal,
It's mild, yes, mild fullness, yes.
but no pain.
No pain. Yeah.
Hmm. Have you got any problem in swallowing?
Swallowing, no.
Hmm. Right. And have you noticed any hard stools?
Hard stool, no.
Hmm. Any yellowish discoloration of the eye?
No.
And how have been your weight? Have you noticed
It's,
any
I didn't
weight?
notice change in my
Sorry?
weight. I
Has it
didn't notice anything in my weight. I feel I'm normal.
normal? All right. Okay. You haven't noticed any change in the size of your claws in terms of if they are being becoming more loose?
No,
All right. Okay. Uh, have you noticed any increase or reduced frequency of your urine or your water work?
no.
Right. Any frothy water
Only
work?
some bubbling. I feel it sometime, yes. And my GP told me it is related to diabetes.
All right. Okay. So you noticed some bubbling. So what about the amount of your water work? Is it normal? Have you noticed any increase or decrease in that?
And I know what's happening sometime my glucose I am measuring it little increase. So I know this time the water work increase.
Mhm. All right. Okay. Have you noticed any specific weather preferences?
No,
Hmm. And how is your sleep?
yeah, my sleep is okay.
All right. Okay. And have you
I
noticed
feel
any?
it in my legs and
Sorry,
hand. But, also GP told me it is related to my diabetes.
what is that?
Numbness.
All right. And for how long you have this numbness in your hands and feet?
It 5 years back. Yes.
Right. Right. Okay. Regarding your loose stool, so have you noticed that kind of a they just are difficult to flush up?
No,
Have you noticed any smell in them?
no.
All right. Okay. Right. Uh, just a few. You said that you have noticed some numbness in the hands and feet. Have you noticed any weakness as well?
No, not
Hmm.
weakness.
All right. Okay. Uh, just a few more general questions. Have you noticed any problem with your vision?
My vision?
Mm-hmm.
Oh, my vision decreased, doctor.
All
It
right.
is my diabetes problem or what?
Uh-huh. For how long you have noticed the vision problem?
Started 5 years back.
Have you seen any eye doctor?
but increased nowadays. Since 6 months, I feel I can't sleep so much like before.
Right. And what kind of vision problem you have noticed?
Blurring, my vision acuity decreased.
All right. Okay. Have you been driving?
Yes, I feel not good during driving.
Yeah, I think I would advise you not to drive till we sort that out because it will be a little bit safety concern for you and the other road users. Is that okay?
Okay, doctor, thank you.
Mhm. All right. Have you noticed any recent change in your diet?
My diet,
Uh-huh.
since يعني maybe 1 year I started some restriction my diet because my weight, my GP told me better your weight to
Mhm.
be decreased. So I
Mhm.
become more to the vegetables and decreasing carbohydrates like this.
So you're taking mainly vegetarian diet.
Yes.
All right. Okay. And may I ask you regarding some general question? It's a kind of yes and no, so you just need to. Have you got any headaches?
Headache, I
Mm-hmm.
think also 3 months I have some headache, especially with my effort.
So, what time of the day you feel the headache is worst?
Time, doctor, anytime, no relation. I think
Any
also
specific?
related to my
Uh-huh.
effort, my
Or
breathing become not good, my heart rate increasing, my headache started like this.
uh-huh. All right. Okay. And have you noticed any racing and pacing of your heart?
Also with my effort, I mentioned, doctor, yes.
Oh, all right. Okay. Right. And have you got, I mean, any problem lying flat, or you feel any shortness of breath when you sleep?
No,
All right. Okay. Uh, so have you ever had any previous stroke
no,
or any heart attack?
no.
How is the control of your diabetes generally?
I think time after this diet, doctor told me number of my 3 months, it was 7. So I think it's okay.
Right. Right. Okay. All right. So apart from metformin and gliclazide, have you been on any other medications?
No,
All right. Okay. Uh, do you smoke
no.
and do you drink alcohol?
Yes, doctor, but actually not too much. I know that it is
Mhm.
affecting my
Right.
diabetes.
All right.
Decrease too much.
All right. Okay. Right. Would you mind if I examine you now?
Yes,
All right. So I'll start examination of the hands and I'll look for any signs of pallor. I will also look for any clubbing, leukonychia and koilonychia.
there is pallor.
Okay. So there is pallor. I would also like to see, apart from that, I would like to examine the eyes. I would like to check for the visual acuity and visual field. And I would offer the fundoscopic examination as well.
Yes, there is a decrease in the vision acuity. It is
Uh,
6/12 both, and uh, uh, there is atrophy in the retina.
mhm. All right. After that, I would like to examine the abdomen of this gentleman.
Yes, what you need?
So I'll just look for inspection first of all, if there's any abdominal distension.
Distendant, mild.
Right. Uh, where is that tenderness?
Distension, mild distension, no tenderness.
Right. And any tenderness?
No,
Right. I would also like to palpate for any palpable kidneys.
no.
All right. Okay. Uh, then after that, I would like to examine the neurological system to look for any signs of peripheral neuropathy.
What you want? Where? And what
Yeah,
you want
yeah. So I would like to examine the feet of this patient. I would like to check the sensations, specifically the sense of position, vibration, and passive movement in
Where?
the whole
Where? Hand, arm or leg? Where?
both. So I like to check these sensation in the feet and in the hands as well.
Yes. On the 4 and 5 and the S1, you will
Mm.
find there is stock appearance of pin break.
All right. Okay. And what about upper limbs?
You will continue to complete the lower limb, or
Yeah,
You
so after that, I would like to also check the power and reflexes and the tone.
okay? The power, it is okay. The power, the
Uh-huh.
reflexes absent in the knee and ankle.
Right.
Uh, Vibration and proprioception lost also up to the knee.
All right. And what? Okay, so I would also like to check the gait.
The gait, there is some ataxia, especially
Mm-hmm.
when the closing is high.
Right. Okay. So there's sensory ataxia, right? Then I'd like to do the same neurological examination in the upper limb, and also I would like to look for any cerebellar dysfunction. I would like to check the coordination and finger nose to look for coordination and.
Coordination is normal, but this time, خلاص, you will bypass. This time you are now 13 minutes. Okay, you have
Okay.
2 minutes.
No, it's at just 12 minutes. So Dr. Basim will alert
No,
when
no,
there
but
will be
this,
two
this
still
minutes.
will take time.
30
No, no, this will
seconds.
take time. Dr. Basim, this
I
will
mean,
take
the
time.
examination steps will take
Yes,
time. It's okay.
yes, yes. Upper and lower limb complete.
Yeah.
Finish. Now 2 minutes, Dr. Hisham.
Okay, all right. So before I go, I understand you work as an accountant. So how this is affecting your job?
I feel my energy very low now. I am taking some sick leaves to not go to come to have some rest. Yes.
All right, okay. I mean, I know, Miss Nadia, what exactly are your concerns?
Doctor, I have many concerns. Please tell me what's happening for me. It is something serious? It is cancer?
All right, I fully appreciate your concern. After taking your history and examining you, I think, so first of all, the cancer seems relatively unlikely. So I don't think that it's due to the cancer. So I feel that most likely your body have a deficiency of one of the vitamins, which is called vitamin B12. And I think that most of your symptoms have been driven by the vitamin B12 deficiency. So yeah, so I don't at the moment. I mean, it could be one of the possibility, but seems relatively unlikely. But uh, any other concern?
Doctor, since 2 months I started to forget many things. My memory becomes so low and I have many falls. It is related to this problem?
Yeah. Before I answer this, can I ask you, do you have any family history of note?
Only diabetes, my mother.
All right, okay. Yeah. So I think that the symptoms of forgetfulness and fall, they could all be related to, and obviously your balance issue, they can all be related to vitamin B12 deficiency, and it can definitely cause this problem.
Okay, doctor, thank you.
Any other concern?
Thank you, doctor. No.
The one thing I would just want to add and tell you that you need to stop your metformin because this is one of the medication that can be associated with uh, vitamin B12 deficiency. And since you have been on a strict vegetarian diet as well, so I think that's something which could also be contributing towards that. So I think that what we need to do is that we need to involve a dietitian to guide you on the diet plan, and we need to do some further blood test, including the levels of your B12 and folate levels, and some other investigation to confirm what we are suspecting as the most likely cause. Is that okay with you?
Okay, doctor, thank you.
Time
Very
is
well.
up. Examiner
No.
question.
Yes, give me your positive finding and your differential.
Yeah, so Miss Nadia is a 50 years old lady who came in with a 6 months history of lethargy. She also has some history to suggest that she has a complicated diabetes with involvement of the multi-organ target organ for diabetes, including kidneys, eyes, and the nervous system, peripheral nervous system as well. For the last 1 year, she has been on a strict diet. She has been trying to cut on her weight, so she has been on a vegetarian diet. Apart from that, she denies any history of alcohol intake. She has no other symptoms to suggest changes in the weight. She is a known diabetic for the past 15 years, and she has been taking metformin and gliclazide. Uh, Apart from that,
Differential.
yeah, so based on this, I think that the differential diagnosis for me, I think that most likely this lady has a vitamin B12 deficiency, and she has likely a subacute combined degeneration of the spinal cord and the brain. That is one of my differential. The second is she has a complicated diabetes with peripheral neuropathy as well. And the other differential apart from that, which could be, I would like to rule out a possibility of a celiac disease as well, although it doesn't seem to be related to any specific diet, the current symptoms, but that's some I would like to rule out. So I think these are my differential diagnoses.
Any other differential?
The other differential could be a pernicious anemia, but yeah, so that could also be one of the reasons that this patient might be having these symptoms.
Okay, doctor, tell me what you will do for her.
Yeah, so I think that I mean, I already have a result of the blood count, but I'd like to do the complete UNEs. I would also like to do the HbA1c. I would like to do a urine analysis and a urine dip and to look for any urine albumin creatinine ratio to see the damage of the. Apart from that, I would also like to do a vitamin B12 and folate levels. I would also like to screen for thyroid, so I'll do a TSH. In addition to that, based on her symptom, I would also like to do a nerve conduction study as well, considering that she has signs to suggest a peripheral neuropathy. So she will likely need a nerve conduction study as well to look for the cause of the neurological symptoms. So uh, I think these are the investigation. I would like to stop her on metformin. So these are the things I would like to suggest at the moment. Another thing I would like to do is an ECG, and also I would like to do an echocardiogram. And she might require a stress test as well, considering that she has shortness of breath on exertion. So I would like to rule out a possibility of a uh, uh, cardiovascular disease in this patient who is obviously at a high risk with multi-organ involvement due to diabetes.
Did you examine her?
I examined the heart.
No,
Uh,
not examine.
no, so I asked about the symptoms. Yes, sorry. I asked about the symptoms, but I didn't examine the heart. No.
What's your treatment?
Yeah, so I think that the treatment of in this patient would be just to, as I said, that once that investigation is confirmed, so it will be a multidisciplinary team approach, which will involve a endocrinologist. The patient will also need help from the physiotherapy. The patient will also need help from a dietitian. And yeah, so I think that might require some social support as well because finding it difficult to drive. So we need to take a little bit more detail of the social history that who is dependent on the patient's driving. So that need sorting as well. In terms of the medical management, so I think that I would suggest to stop this patient's metformin, considering that she has vitamin B12 deficiency symptoms. So I think that metformin, I would like to stop that out. In terms of the management, as I said, that we need to replace that vitamin B. First of all, we need to see that whether it is just a B12 deficiency or the patient is deficient in folate as well. So if the folates are normal, then we just need to replace the vitamin B12. Need to improve the control of the diabetes as well. And so I think that mainly these are the main lines of management for me. And regarding involvement of the heart, so we need to see that after the ECG and echo, and then treat it accordingly. Regarding the neurological symptoms, the neuropathic pain, so they might get better with the B12, but the other possibility in a neuropathic pain could be medicine like gabapentin, which can help with the peripheral neuropathy. I would also like to involve the eye doctor to have a look at the eye because the patient might be having proliferative or pre-proliferative retinopathy and may require treatment in that regard as well. So as I said, it will be a multidisciplinary team approach to address and manage this patient.
Okay, doctor. You will send for her vitamin B12 level, right?
Yes.
It come normal.
So the vitamin B12 level came back normal.
Came back normal. What you will
And
do? Anything else?
yes, I think that there's another test which we do, which is called um, something. Uh, starting from M or H, I think that. So we do RBC folate, and we also do another test. I remember that there's more specific one. I just
Dr. Ihtisam. Yes,
so there is sorry.
مثاله malominic level.
Yes, yes. So
This
I
is the
forgot
enzyme
the thing.
functionally affected vitamin B
Yes,
due to
yes, yes. Yeah. Methylmalonic acid. Yes, you're right.
any other lab you would send.
Uh, I mean, we can. I mean, if there's a concern, we can do some imaging as well, and that could be that
Not
could be
imaging lab.
sorry,
Lab,
sorry.
not imaging lab.
Uh, because one of the concern of obviously the patient is having a cancer, so maybe you can do a stool analysis as well to look for any. Uh, I mean, we can do a
You
stool
will
fit.
transfuse blood for this patient.
Sorry.
You will transfuse blood.
I mean, she might require blood transfusion, but seem more chronic. So it all depends that how, because now she's having symptoms of heart failure as well. So symptomatic improvement might, I mean, if she's not actively bleeding and no active symptoms of heart failure, then it is fine to just replace the
Did you ask
B12.
her about any source of bleeding?
Any other source of bleeding?
Yes.
I asked about GIT bleeding. I asked about the
You asked
urinary.
you asked it only in any black stool.
No, I asked any blood in the stool as well.
Yes.
I asked about any blood in
Otherwise,
the stool, and I also asked black stool, and I also asked about any blood in the urine as well. I think so.
okay, Dr. Sam. Thank
Yeah.
you. طبعا you are ما
Okay,
شاء الله
okay,
very
okay. You can comment now.
yes. لا ما شاء الله Dr. Ihtisam very good. He catches the diagnosis. I think regarding the communication, I don't know. I usually can't comment about the communication and the history because I'm concentrating on the judgment. So Dr. Basim will tell يعني I think you jumping from here there يعني diabetes complication you ask about it late some of them early some of them late uh, from the beginning يعني the patient hemoglobin 7 heart rate 100 or 95 plus and blood pressure low very important question at the beginning any bleeding anywhere and it's very important the beginning of the approach because maybe emergency so after that you go to the GI you take it the relevant system then to the I think from the beginning to the family history the past history from the beginning directly you go to the past history constitutional I think you didn't ask about temperature sweating um,
Yes, I didn't ask about that. You're right. I mean, I just asked some targeted question, but I think that I just
yes
asked about the weight
I
and whether
noticed
yeah.
I noticed all your question targeted more. It is not. I think Dr. Basim will cover this area,
I
but I think it
intentionally
was more
target.
targeted.
Yeah. I
This
just
50-year female, and even you didn't touch at all the pregnant, the period problem. Patient, you didn't ask her. Maybe she has menorrhagia. She has problem in
yes.
the period.
I missed that. Yes.
As a
Yes.
source of bleeding, yeah, right. Yeah, and what I mean that the entrance of the approach, I doubt it was very good. You reach the diagnosis. I will mention now the diagnosis. You reach it, very nice. But I think they are not giving the marks on the diagnosis. You can bring the diagnosis from first question from the patient.
Yeah.
They
I
will
I
be
just wanted to ask you, and obviously Dr. Basim is also here because here in this patient they have given an HB and MCV of 110. So when I saw an MCV of 110, so I just switched my mind to causes of macrocytic anemia, to be honest. So I was not thinking about bleeding from any source because it would have caused microcytic anemia, like if there would have been bleeding from the GIT, if it would been bleeding like a menorrhagia or bleeding from anywhere else. So it would have been a low MCV because that caused low or iron. Because it was written outside that this is a macrocytic anemia, so that's why I just went in a targeted approach. So I don't know, I mean, is it right or wrong? Because then when I was outside in those 3-4 minutes, what I did in my scheme was I just put up the causes of macrocytic anemia, that it could be B12, could be folate, could be alcohol, could be hypothyroidism, could be due to diet, could be due to myelodysplastic syndrome, and all these things. And then when I started asking question, so I went in a targeted way. So I don't know, because iron deficiency and things like that, I mean, I was not thinking on that line, to be honest. So Dr. Basim, or you can
Yes,
guide me
I will
further.
answer this particularly.
Yeah.
If you have even macrocytic anemia and suddenly this patient had any GI loss, do you think the MCV will be changed acutely?
This is my answer.
Yeah.
Yes.
So it will be like something acute. You have to rule it out just to show the examiner. It's not.
Hemoglobin 7, Dr. Basim, is
All right.
acute. Hemoglobin 7,
Yes.
it is significant. It is not.
Yeah. I want to say, yeah, you have to rule out the serious bleeding, whatever the MCV there. Yes, you have to find the diagnosis, but you have to rule out as well the
Blood
dangerous
pressure is
bleeding.
low and heart rate is
Yeah.
high. Patient is symptomatic heart failure. It's acute.
Yeah,
There
that's
is
why
something
I answered this part particularly. Yeah, it's not the matter of diagnosis, the matter of rolling out something serious ongoing. Some patient they have macrocytic anemia, but they are presenting with GI bleeding. Yes, you might have the MCV low for the chronic anemia. At the same time, you have to rule out the question for acute anemia or acute blood loss. It will not come as positive in this situation. Okay. You got
All
it,
right.
Dr. Ihtisham.
Right.
Yeah, it's a
Right.
matter of rolling out. It's not confirming diagnosis. It's
Right. Right.
rolling
Right.
out.
And
Okay,
yeah, one
continue.
more
Yes.
thing is that the blood pressure was written 110/60. Will it come under as a low blood pressure? 110 over
If
60.
if the patient is hypertensive,
with
you
this
will
heart
consider.
rate and the age and كده it should be more. يعني it should, some patient has comorbidities like diabetes long term. Usually they have some high pressure. It is no. This is low with heart rate high. This heart rate 95 or 100. I don't remember. But this
90.
Not only
and
that, the tachycardia also is there. So there is something ongoing. There is something
and and
cooking.
during the history, Dr. Basim, يعني I mentioned from I am the one, the surrogate, till him, I have fall down. Maybe fall down. This is he has dizziness. If you ask him, he has dizziness when he stand up. So he has
Mm.
symptomatic vitamin B
Anemia.
deficiency or acute
Not.
anemia happened to him. Yes.
Yes. This is what I want to comment. The dizziness itself from sitting to standing, I guess it's one of the welfare point. Any
Yes.
anemia patient. By the way, Dr. Hisham, if they give you the investigation, the lab work up outside, you will conclude and you will narrow your differential. Here, they give you even the MCV. I think before going to the station, you have three differential, which are the one you got out at the end of the station: the pernicious anemia, the megaloblastic anemia because of vitamin B12 deficiency, and you can also say alcohol, right? Alcohol. You didn't ask about alcohol, by the way. And one of the
He asked me. He
macrocytic
asked
I
me
anemia.
about
asked.
He
that.
asked, okay,
I
sorry.
asked. Yeah.
Yeah, it's okay. It's one of the causes and hypothyroidism, right? What I want to say, it's good to have some lab tests. You can narrow your differential more, and you can reach to the case from the start. If Dr. Muhammad finish, I will comment
No, I
on.
still have some
Okay,
comment.
continue the skills and give me the skill. Let me comment on the clinical communication skills only. Okay, continue
Yes.
other skills.
Yes. This my point only on the communication. The entrance was little في some issues يعني. Then during the examination, uh, the same as with me. You this case little history, more examination. You will take the hydration, the fundus, the vision, and general examination, neuro examination. You take upper and lower. It is very difficult to do this in the exam. You suspect there is vitamin B to vitamin B12 deficiency, so subacute combined degeneration. You didn't confirm by plantar abdomen, going to confirm your diagnosis. And usually you are going there, you are suspecting subacute combined degeneration will be targeted. One from pain, one from vibration or proprioception, one power. And the good thing that you do the gate and you catch it that there is sensory ataxia, and I don't know you asked for Romberg test or not. So what I mean, you need time. You need time for such a case. You catch the diagnosis, go to the exam early, because you need to confirm, and you have this symptomatic heart. It's very important to check the heart if there is gallop, third sound, fourth sound, crackles in the base of the lung. This will guide you. Then the management is there is acute management for the patient with acute heart failure. And this is regarding the examination. Regarding the diagnosis, yes, it is symptomatic vitamin B deficiency, subacute combined degeneration due to the metformin long term. She's taking for 20 years and started vegetarian due to the restricted diet, vegetarian diet. This is the main diagnosis. The other diagnosis, yes, and you didn't mention pernicious anemia at the beginning. She is pale and she's have the big needles in her hand, and so one of the diagnosis pernicious and celiac. Despite during the history you didn't ask here, it is related to any specific food. You told only loose motion, where, when, but you didn't specify to confirm it is celiac or not. Yes, you told about surgery. You declared it from the diagnosis. So it is vitamin B. And better to tell the hair about the diagnosis directly. You catch the diagnosis. You have this subacute combined degeneration. It is related to your vitamin B deficiency and affecting your nerve cable and affecting or causing all these symptoms. Then regarding, but this is the differential, you will be satisfactory. Really, you, mashallah, you bring it very nice. Even the concern, you advise it, but only at the one of the description of the diagnosis, because you catch it. It is not a differential. It is if you complete a blunter and خلاص you confirm it is subacute combined degeneration causing all this, even the memory. She is causing memory problem. She is causing atrophy in the fundus. All this because of she has 1 year vitamin B12 started to be deficient, or many years started gradually to be deficient by the metformin and increased by the vegetarian diet. Regarding the so the concern and differential satisfactorily. Regarding the investigation, despite you told the diagnosis very nice, you didn't tell your investigation to be sure to confirm your diagnosis well. I don't think you told vitamin B level, folic level, iron level, iron studies, all antibodies, autoimmune antibodies for the celiac, and even you can tell celiac serology, antiparietal, and it's a very important antiparietal and anti-intrinsic factor. And طبعا vitamin B level, if it is normal, طبعا he will not decline your mark for mesalaminic acid. And the other test, homocysteine level. Homocysteine level also increased by, it is a marker, indirect marker for vitamin B12. If it is not available and homocysteine available, both this mesalaminic and homocysteine, it will direct you that there is some problem in the vitamin B level. Yes, regarding the neuro, you mentioned, regarding diabetes, you mentioned diabetes, hemoglobin A1C and all relation. Neuro, nerve conduction velocity, you mentioned it. To confirm, and yes, the treatment, you can طبعا the only treatment is vitamin B replacement, and you can mention for him the protocol or the regime. It will be better, it will impress the examiner. It will be for 5 days, 1000 per IM, then weekly for 1 month, then monthly for 3 months, then long term or maintenance after that. And yes, very nice. Welfare, you stop the metformin and stop driving. Education طبعا must be for the patient. Counseling, make her away from any risky hobbies, risky machines, risky like this, because she's losing her balance. If she close her eye, she will be fall down, and she's telling I am falling down all the time. Also, the entrance of the treatment, it is patient have dizziness, have fall down, have pallor, have very low. I will confirm the hemoglobin level. I will start maybe need blood transfusion. I will confirm the heart failure. يعني give some hints that there is maybe some emergency for this case. And confirming يعني no other source of bleeding for this patient. Okay. All the other multidisciplinary team, as you mentioned, endocrino, diabetes, the dietitian, also some rehab for this affected limbs, and the counseling for the patient about that. Okay. But you did very well, Dr. Hisham, really. Only يعني not too much mark will be declined from you.
Yeah, thank you, Dr. Muhammad. I will add to your comment from the last point you mentioned, the anemia. It's not this case only. Any anemia patient in the exam, whenever the patient presents with symptoms, please start with ABCD approach, including blood grouping, transfusion if patient having symptomatic anemia. For all cases, not only this scenario particular. Okay, Dr. Hacham, put it in your mind. However, your plan was good. Once when the examiner asks you what's your management plan, you impressed me when you start by saying multidisciplinary team. Most of the doctors, they will think the first thing I will check for folate level and I will correct the vitamin B12 first before, if the folate is deficient, I will correct the folate after correcting the vitamin B12 level. This is what we usually do. Whenever we have such case, we are thinking about the pharmacological option. But the good thing here, you mentioned the multidisciplinary. But I want and I wished to start with even the multidisciplinary, not multidisciplinary, the ABCD. Patient is dizzy, falling down, anemic heart failure. So I will start ABCD approach. Then if he needs some blood or any blood, I will do a cross matching in order to transfuse him whenever he needs. I will go to the clinical communication because I think this skill related to our session more. I felt, as Dr. Muhammad said, you are going from here to there once you started the questions. And you have the differential already for your diagnosis. What I prefer to do, follow the scheme, always follow the scheme. Don't ask the question, looks like you are asking randomly question. So it will show the examiner that you are not regular, not organized, and they will minus you, believe me. So the best way to do here, even the target question, you miss some of the important question. So what if I have patient with night sweats? Yeah, it's not the case, but don't depend only on the weight or the appetite. The all questions as a package, as always saying, loss of weight, loss of appetite, lumps or bumps, fever, night sweats. What the matter if you ask them? It might take only 20 seconds. But I fulfill all the constitutional symptoms. I will not waste any of these. Next system, the systemic review question. I wanted to start from the head to toe. Earlier, you asked about the diarrhea. Then you went to the headache. Then the short of breath. Even you missed very important system, which is musculoskeletal. What do you think if this patient is having pernicious anemia? What do you miss in what system you missed will guide you to the pernicious anemia? Dr. Hacham.
Yeah, I mean, so you're asking about the associations.
Yeah, not association. What system in the systemic review will tell you this is pernicious anemia?
I mean, it could be GIT and the
Okay,
other.
finish the GIT. What else? Tell me the manifestation of the pernicious anemia.
Yeah, so pernicious anemia, the manifestation could be GIT related.
Okay,
Then it could cause neurological problems.
okay,
Yeah, the other thing then there could be consequences of the anemia, and
okay,
yeah, that could lead to anemia related manifestation like a heart failure symptom, headache, angina, and things like that. And apart from that, then we can
Yes.
look for the association because it is an autoimmune thing. So we can look for the endocrinology thing, look for any features to suggest hypothyroidism. And I think this is another one. And also, a patient already had a type 2 diabetes. So I think these are the main system to target. I don't know if anything else. Musculoskeletal.
Yes, musculoskeletal. Finally, you mentioned them. Tell me.
So you want to ask me what is the association of musculoskeletal with?
Okay, tell me what
I
are
mean,
they?
I mean, there could be association with vitiligo, but I don't know what other. Yeah, there could be association with rheumatoid arthritis as well.
This
And
one of the calibration, Dr. Basim, really. They should
sorry.
Sorry?
mention LIGO and BIHST or something يعني related to the musculoskeletal.
No, even rheumatoid can be associated with pernicious anemia because that's also being
You
Okay,
didn't
another.
touch
let's
it.
let's let's ask, but in particular about angular stomatitis. Is it there?
Uh-huh.
Yeah, this is a question. If the patient possibly he is pernicious anemia or she is it possible to have angular stomatitis?
Mm, I think it can happen.
Yes, right? It's one of the manifestation.
Yeah.
So if I am guessing this case could be as pernicious anemia. Sometimes it comes, by the way, right? Pernicious
Right.
anemia comes in bases.
Yeah, yeah. It actually does come. Yeah, you're right.
Yeah, this is why I want you to ask about every system. Even you can say along with that or against that. So what is with
Bring a
this?
patient, Dr. Basim, with really with musculoskeletal, autoimmune. You want to search for all this.
Yeah. Plus, but angular stomatitis, I think it's more characteristic to the pernicious anemia, right?
Yes, yes, angular stomatitis diagnostic. It is one of the يعني from the
Yes,
stigmata.
pathognomonic. Yeah, I
Yes.
mean, it came before Dr. Hisham. Believe
Well,
me.
Dr. Hassan didn't touch musculoskeletal at all, I think.
Yeah, this
All
is my point.
you
Not
have
only,
difficult swallowing only. No ulcer, no dry, no tightness,
yeah.
no, I think like
So what my point is, finish the systemic review once you start from head to toe in regular and organized way to show the examiner that you are rolling out everything, covering the all systems, because you might forget one of the systems, which will be very dangerous in your station.
I
For example,
sorry,
here,
I still couldn't understand about musculoskeletal. So what exactly? I
no,
mean,
no,
that's
I mean not in our case today. I am guessing that if you have pernicious anemia patient and you
uh-huh.
didn't ask about angular stomatitis, you might miss the case, right?
Yeah,
and
yeah,
it is one of the differential, Dr. Hisham.
Yeah, even
Pernicious.
it's one of the
It
differential. You
is
can
one of
say
the, he
against.
can make this case, يعني he can bring this case, same subacute combined degeneration, and the diagnosis, it will not be vegan
Yes, it came
or
before,
he
by
will
the way.
bring for you musculoskeletal. He will bring for musculoskeletal, yes.
It came before Dr. Hisham. This is what I want to say. Pernicious anemia can come with the same presentation: lethargy, anemia, and vitamin B12 deficiency, peripheral neuropathy, along with the angular stomatitis. Okay, so even you might have the same MCV. My point is, you can have either this diagnosis or that diagnosis based on the systemic review to roll out or to roll in. So please try
Mhm.
to fulfill all the systems. You might have something you can miss. Here, if you didn't ask about numbness and tingling, you might miss the case, right?
Mm, yeah.
Okay. So
I
this
am
is
the
regarding
one,
the,
I am the to him the this key, Dr. Basim. I told him I have, he told me any problem in your sleep, right, Dr. Hisham? You told me like this. Then I told you I have some numbness on my hand and the leg.
yes, yeah, yeah. I think yeah, it was like a volunteer by Dr. Muhammad.
Yeah,
Okay,
because
listen.
yeah,
Yeah.
but I think that I was targeting to ask
Yeah, what?
all the complications of diabetes as one package. So I mean, this was something I was targeting. I was thinking to asking. I mean, think I was thinking to ask about vision problem, heart attack, stroke, numbness, tingling.
Yeah,
So I mean, so I
I
was to
prefer
ask
to ask
those
this
questions.
question in the systemic review, by the way.
Yeah.
I did it one of my station and one of my exams. I did it in this way. Start the systemic review, finish the systemic review, then I start to ask about the macro and micro and macro vascular complication. And he minus me. They wrote for me not organized. See, I started systemic review, then the diabetes communication the same as you did, and he minus
Mm.
me in the clinical communication, written in brackets. It was unorganized or not organized history taking. Although I was following the scheme, but because I started the systemic review and then the diabetes because it seemed like you are going from up downward, then you are
Uh-huh.
going again from up downward for diabetes. Why you are not doing it together, them together?
Hmm.
It sounds like you are disorganized. You're asking from here and there, diabetes, headache, peripheral neuropathy. Then you are going up to again, a stroke, heart attack. Okay, why you didn't ask them in the same time with chest pain? The heart attack, it's the same
Hmm.
as chest pain. Okay, so I prefer to do so. Anyway, let's go to what test could be conclusive for dorsal column. You didn't do. I wrote it in the chat box, by the way. It's diagnostic and to differentiate between central and sensory ataxia. What is this test?
Romberg, Romberg,
Ex-
Romberg.
Yeah, exactly. Whenever you have peripheral neuropathy, try to finish the steps of motor inspection, as we know, motor power, reflex, coordination, sensation, gait, and the Romberg to confirm this is dorsal column, not central ataxia,
Mm.
particularly here in this scenario, right? Because you want to say this is vacuum
Yes,
combined.
Dr. Bassem, Dr. Hisham, he can take the lower limb only enough.
Yeah, yeah.
Once
I
you have
prefer. Yeah,
suspension
yeah.
subacute combined, because many I take the case not in directly, I indirectly I was listener, and the same the candidate do upper, then go to lower, then the time pass, and he didn't do the full
Exactly. Yeah.
subacute combined gene
Yes.
test. يعني the examiner told him how you confirm it is subacute combined. You didn't do Blanter, you didn't do Romberg, you didn't do like this. You only test Bembrick and stock appearance. Maybe this from diabetic nephropathy.
Yes.
Diabetic
Exactly.
Mm.
nephropathy, he can have the same sensory ataxia.
Yes.
But what if the
Yes.
test confirm it? A Blanter and loss of knee and ankle reflex. And Romberg test to confirm after that ataxia and
Yes.
the
Anyway, we are learning from the cases, complicated cases. I wish to practice all of them nowadays, both of you, because the exam is so close, and try to be harder the level of the gaming as you did today.
Mm.
So don't feel upset that it was difficult. It was some tricky question, twisted answer. Yeah, it's good to be difficult now rather than being mentally blocked in the exam with the question. But please follow the approach, do the scheme well, and they can even give you good mark even if you will not reach the diagnosis. Okay.
Right.
Yes. Okay. Any question, Dr. Hacham, Dr. Muhammad?
Hisham, really, wallahi, very nice.
Yes. Both of you should focus on the system review. This is what I realized that both of you are defective in the same system and the
Yeah.
same.
The
Yeah.
problem is to follow the
Yes.
scheme.
The system review. I believe it's very important. I always focus on
And in
this
my
part.
case, this case that I bought, it is clear. Subacute combined degeneration. If he go this the approach, he will catch it. It was for examination and the treatment. This was the tricky, and this was the tricky. Yeah, the question
Yes.
was, vitamin B level normal. What you will do? This is a high
Mm-hmm.
level of question to give him the
Yes.
full mark.
Yes.
But for his case with me, يعني diarrhea, lose motion, and go to the acromegaly and go here. It was very difficult, really. يعني
No, it's the same defect, Dr. Muhammad. You miss one of the systems, that's why you miss the case. Dr. Ihtisham also, although he catch it, But I think the good question here, which help him, the diet. And also you were volunteer to say, I started on the vegetarian. Maybe the surrogate will tell you, yes, I'm being restricted nowadays without mentioning what type. Unless you ask him more, squeeze him, then he will say, yes, I was focusing on the vegetarian food
Doing
only.
the verbatim once he touches
The diet.
the
Suppose in the
diagnosis
exam, yeah, the surrogate will be helpful, not as
this is what's happening. This is what's happening really.
yes, of
يعني he
course,
will not
yes, yes.
يعني he will hide for you. No, what
No, no,
once
no,
he
no, no. Yeah, he should. Once you open up, he will.
yes.
Once you ask, he will open up. So don't think that he will hide. No, it's not. If you didn't ask, yes, he might hide. But once you ask about something can help for the diagnosis, he will open up. Okay. Yeah, the female history as well is very important in this scenario, not only for the period, the pregnancy, the bills. So it's very important. Maybe this patient is pregnant now. What do you think the importance of being pregnant in this scenario, Dr. Ihtisham? Do you think it's important to ask, are you pregnant by any chance in this scenario?
Yeah, I think that, I mean,
Yeah.
obviously, if she's pregnant, so the anemia is
Yes.
likely to get worse.
Yes, exactly. The patient will have severe symptoms of anemia because she had another life in her tummy, right? So please focus on the system review questions. Don't forget the female and the other system review. Okay. I think we,
Dr. Basim, I just wanted to ask you that
yeah.
this is a kind of question I am a little bit reluctant at time to ask. The other day there was one patient who was 54, and the same thing I missed in one of the other practicing session, and that I didn't ask the female history. So I'm not sure that till what age the pregnancy history is important.
Yes, this age. What the age of this patient?
50,
No, no, it's 30. Wait. It's
50,
30 or
50,
50?
50, 50.
Wait. Sorry, if 50, yeah, this is my mistake. I'm thinking about 30. That's
No, no,
why.
50.
No, no, I'm sorry. No. This is my mistake. No pregnancy here. You cannot ask this question. It's something out of reality. So I'm so sorry. I thought it's 30. However, you have to remember to do it. And if in such age, don't ask about the pregnancy per name, so or per se. Only ask about the birth control pills previously, any bleeding or a change of the period. Of course, here it will be menopause, but I wanted to remember this part in the system because if you miss it in earlier age, you might miss a case if there is, for example, postpartum cardiomyopathy or postpartum thyroiditis or peripartum cardiomyopathy. Okay, so try to
I think
remember.
pregnant up till 45. I think I didn't.
Yeah, yeah.
I not
But
confirmed.
50 is
I
difficult.
think, yeah, Dr. Basim, I was just trying to figure that out, and I was just thinking that I'll just ask period related question. If the patient obviously is having normal period, so potentially she could be pregnant, and in that case, we can ask. But if she already reached menopause, so then there is no point in asking that. I mean, it can happen obviously if the patient is uh, I mean still having the periods, and if she's still having so there is a possibility that although but I mean this is something which we do see that can happen, and it's relatively more we see that kind of if you are appearing in UK and all these. So generally, that's something which can happen. So I think that it would be safe if I can just ask period related history, and if that's positive, which means that the patient is still having not reached menopause. So in that case, I think it would be
Yeah.
okay to ask. What do you think?
Yes. It's really a very important question. It might be bleeding even with menopause. As you know, there is some fibroids, even with menopause, they can have
And
some abnormal bleeding, and this bleeding might
and
cause.
sometimes they're taking SOC combined build for this, and maybe it's one of the important question. This you are taking pills to control pills in such a case anemia, severe anemia for bleeding, any bleeding there. It's very important.
So shall I not ask this question, Dr. Mohammed? This is my question, that if someone comes up with a 50 years age and if she is still menstruating normally, shall I ask this question or not? So this is because if this is a question not to be asked and I ask, then it's directly related to patient welfare. And you know that in welfare you don't have much margin. So what should I do in that case?
No. If you ask about female history, not as even the period, you can see any bleeding from anywhere. It's enough just to show the examiner that you are remembering the female history. It's not that like earlier or childbearing age, like pregnancy, or you can ask about birth control. Sometime not only for the period, sometime for the flushing. They are taking this pills, right? Some of them they have abnormal bleeding, and sometimes they can have hormonal replacement. So at least touch one of these questions, but don't ask the question who's beyond the age. Like, are you pregnant in 60 or 55 or 50? I don't think they can bring with this history. Maybe for 40 maximum, but difficult
40s
to bring.
or the 40s. I think
Yeah,
from
but
50 you can't ask except there is يعني I think
yeah,
rare and he will
yeah,
bring
but
you.
basis
Yeah.
wise, I'm talking about basis wise. They will not bring something out or beyond the nature, right?
I think
Right.
the 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 age will come يعني in the age of extremes. Not he will not bring والله 48 and to ask about pregnancy. He will not be. He will bring the early 40s or 50 and above to be
Yeah.
away from this area of
Yes, exactly.
and
Yes.
you don't realize what about your period, it is regular or not, and according every case يعني we are here telling about a severe anemia يعني you must see where it يعني as a female it's a very important genitourinary for her about the bleeding. Maybe she has a
Yeah. Abnormal bleeding, exactly. So not only as a period, even abnormal bleeding. Some of them till the age of 55, 60, they have abnormal bleeding, which can lead to the again iron deficiency anemia. So it's a matter of covering every system, not to miss by only one question. That's enough. This is the take-home message for systemic review is very important. Dr. Muhammad and Dr. Ihtisham, you have one more chance to practice long without forgetting the systemic review before your exam, I think next week. So if there is opportunity, please do it. I wish I can see it before the exam to be sure that you can do it in the exam properly. Okay. Thank you, Dr. Hacham and Dr.
Yeah.
Muhammad.
Thank you.
Yeah, it's almost 2 hours this session. I hope you all of you got the benefit. The comment quickly. I don't think, yeah, Rumberg test, multiple endocrine neuropathy, Dr. Aisha vitiligo, yes, as autoimmune association. Sometime menopause at age of 55, yes, I agree. Estrogen, as I said, yes, it can cause, and it can have association. Uterine bleeding, yes, Dr. Ashayma. Thank you, Dr. Hacham, Dr. Muhammad. Thank you, everyone, the attendance. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you. Assalamu alaikum.
Alaikum assalam.